Welcome to Dr. Balga's podcast for the Curious Doc. Today is March 18, 2026. This video is on a Nature article published on 16 March 2026, open access, titled Insulin Resistance Prediction from Wearables and Routine Blood Biomarkers. There is an accompanying News and Views article titled Data from Smart Watches Reveal Early Signs of Insulin Resistance. Insulin resistance is an early driver of type 2 diabetes and cardiovascular disease. Current diagnostics include insulin clamp, the homeostatic model assessment of insulin resistance, and these are costly and require lab testing. This WearMe study enrolled 1,165 adults, median age about 45 years, body mass index about 28 kilo per square meter, remote design using wearable devices and routine blood biomarkers. The homeostatic model assessment of insulin resistance is calculated from fasting physiology, fasting glucose and insulin. Insulin resistance is defined and greater than 2.9. Inputs include wearable signals, heart rate variability, steps, sleep, demographics, and biomarkers. They use deep learning models with masked autoencoder and XGBoost with 5-fold cross-validation. The wearable foundation model was pre-trained on 40 million hours of sensor data. What they find? The multimodal model achieved area under the receiver operating curve of 0.8, sensitivity 76%, specificity 84%. Wearables with demographics alone, the area under the receiver operating curve was 0.70. It improves the glucose and lipid panel. The best regression performance R squared was 0.50 using wearables and biomarkers. The wearable foundation model improved the area under the receiver operating curve up to 0.8 with biomarkers. Independent validation cohort of about 72 individuals. The area under the receiver operating curve improved from 0.66 to 0.88 with wearables. Key correlations: 0.57 with glucose, BMI, the R was 0.43, with the hemoglobin A1C 0.45. With triglycerides, it was 0.40, p-value less than 0.001. Negative correlations include HDL, R minus 0.3, steps or exercise R equals 0.25, and heart rate variability R equals 0.14, p-value was less than 0.001. 20% of the normal glycemic individuals already had insulin resistance. The key takeaway: limitations, selection bias, wearable device homogeneity, and there's a lot of variability in insulin resistance as measured by HOMA. The News and Views article discusses the advantage of wearables is from snapshot to signal. Conceptual shift: episodic testing captures late disease, while wearables provide continuous physiology. The key insight: insulin resistance remains hidden despite normal glucose due to compensation. The innovation in the study: multimodal signals reveal coordinated and metabolic stress, not isolated markers. Clinical implication: expands early intervention window for lifestyle modification. Philosophical pivot: disease is a trajectory, not a threshold. The caution about generalizability, causality, and outcome benefit requiring proper validation. What are the clinical pearls of the study? Insulin resistance can precede abnormal hemoglobin A1C and fasting glucose. Wearables enable continuous scalable metabolic surveillance. Multimodal data integration substantially improves prediction accuracy. Foundation models capture complex physiological patterns beyond simple averages. Potential triage tool to identify patients needing formal insulin testing. May refine targeting of GLP-1 and metabolic therapies beyond body mass index. It supports early lifestyle intervention before over diabetes develops. This, in a nutshell, is a fantastic article. It's open access. Go ahead and read it in Nature. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.